Assalamu alaikum everyone. My name is Mohammed Ali. I'm a student from University of Sharjah, and for today I will be explaining for you the anatomy of the brain stem, both the internal and external features. But before we start, as an advice, I highly recommend that you study the tractology lecture very well and to memorize the 12 cranial nerves and what each nerve does and what happens if there's any lesion in that nerve. With that being said, how this lecture or how this video will be divided is that we'll go through each part of the brainstem. Let's say the midbrain. We will study the ventral aspect, then the dorsal aspect, and then we'll go through the internal features of it. So let's get started with the basics. So you have the brainstem. How does it look? In order, you got the midbrain to the pons to the medulla, as you can see here. This is from the lecture slides. Let me show you a picture from the internet I got that's very clear. Here you start with the midbrain, بعدين to the pons, and here is the medulla oblongata. Here is the dorsal aspect of it, midbrain, and then pons, and then the medulla oblongata, and here is the lateral aspect of it. Okay, here's how it looks when you see it as a whole picture. I thought of putting it in for you to see. General functions, simply, the brainstem is the relay center, transmitting signals between the brain and spinal cord. It contains the reticular formation that regulates the vitals. It is involved in consciousness, sleep-wake cycle, and coordination of movement. And it is the site of origin and emergence of the cranial nerves from 3 to 12. So our story starts from cranial nerve 3 up until 12. That's very important. Okay. Here you get just from this slide the general relations, and then here we start the actual story. Now, you got the brainstem. Behind the brainstem, you got what? The cerebellum. Now, between those two structures, we need to have attachments. Those attachments are called cerebellar peduncles. We got three parts: superior cerebellar peduncle, the middle cerebellar peduncle, and the inferior cerebellar peduncle. Let's take a look at them. Here's the superior cerebellar peduncle, and if you go directly under it is the inferior cerebellar peduncle, and then you got the middle cerebellar peduncle, which is the largest out of the three. Okay, and each peduncle we got two pairs. So here's two attachments to the midbrain. That's the superior. It attaches between the cerebellum and the midbrain, and then you got the middle cerebellar peduncle attaching the cerebellum to the pons, and the inferior cerebellar peduncle from the cerebellum up until the medulla oblongata. Okay, so we got a general orientation. Let's actually start the midbrain, ventral aspect. So if we take a look at the midbrain itself, here's the midbrain. Okay, and here's also some boundaries that we will see. First things first, or two things that you will immediately notice is that we have a fossa called interpeduncular fossa, and on the sides we have the cerebellar peduncles, which other name for it is the crus cerebri. So we got the crus cerebri on the sides, and between them is the interpeduncular fossa. Inside the fossa, as we always know, there is content that we'll talk about it, and around it we have boundaries. So let's take a look at those boundaries. Let's go from most superior here until we go down, and then we'll see these structures. So at first you see the optic chiasm at the most superior part, and then if you go down you'll see the optic tract, and then if you go from here you'll see the crus cerebri from both sides, and then if you dig inside, deep inside, you will see the following structures. Let me go to the slides so that I show it to you. Here it is. Here you will see the most superior structure again from the inside, from the fossa inside. You'll see the infundibulum. If you go down a bit, you will see the two mammillary bodies, and from within downwards you will see the posterior perforated substance. And with that we have got the general idea. Now let's take a look at the nerves. This is very important, at the nerves. In general, in the midbrain we have two important nerves, the oculomotor and trochlear nerve. Okay, the oculomotor, you will see it here. Notice that these are the two oculomotor. Notice that it arises from the ventral aspect. Okay, it's very important. It's the third cranial nerve. So notice we will be studying the nerves in order, from the midbrain up until the medulla, cranial nerve 3 up until the 12th cranial nerve. Okay, so here you got the oculomotor nerve. What other things we will see بالفصة? We will see the circle of Willis. This is very important. It has a collection of arteries. So here, as you can see in this picture, all you need to know here is like just be able to identify some parts. The circle of Willis is composed of the basilar artery. It's located in a different area, not the midbrain. And you got the middle cerebral artery, and if you go above you'll see the internal carotid artery. Just know the features, and know that circle of Willis exists within the interpeduncular fossa. That's very, very important. Here I have attached from a picture from Ambos. It shows you the middle cerebellar artery, and here it is basically, and here is the basilar artery. The basilar artery, again, you will see it in a different area in the brainstem. Okay, let's see here. We already talked about the nerves, so optic tract, oculomotor, trochlear. Notice something, the trochlear, I talked about the oculomotor. Notice the trochlear is also seen, but it does not arise from the ventral aspect, but rather it arises from the dorsal aspect, and it goes circles around until it reaches to the ventral aspect. And that's the only nerve that does that. The only nerve. That's also important. Okay, let's go through the vascular structures. You got two important things. The posterior cerebellar artery, which has a very important clinical relevance, and you have the basal vein. Here it is. This is the posterior cerebellar artery and the basal vein. طيب, if this artery got dilated and it pushed the structures here, it pushes the structure and it caused some problems in the nerves here, or maybe perhaps this artery got an aneurysm and some complications occurred, what will be the nerve here that will be affected? Well, the nerve here that will be mainly affected is the oculomotor nerve. But why? Why is not trochlear affected? Because the oculomotor nerve, which arises from the ventral aspect, and that the posterior cerebral artery, who is also arising from the ventral aspect, if it gets affected, it will affect the closest nearby structure, which is the oculomotor. And if you got a good idea about the function of what does this oculomotor does, which is motor, and oculo, which is eye-related motor functions, you will have a good idea of what will happen if you got an injury. We will see this further in the internal features. You got a whole syndrome there. Okay, and what else from the ventral aspect do you see? That's about it from the ventral aspect of the midbrain. Now, I want to introduce you to a really nice rule. Now, told you that we have cranial nerves from 3 up until 12, right? Well, there is a nice rule you can follow for the ventral aspect only, where you can go through each nerve in a nice sequence so that you will never forget what nerves exist in what part of the brainstem. So starting from cranial nerve 3, you use the rule of 2, 4, and 4. So you just count cranial nerve 3 and 4. Those are related in the midbrain. Then you go for cranial nerves 5, 6, 7, and 8. That's in the pons. And then 9, 10, 11, and 12, the last 4 is located in the medulla. Okay. By the way, you may ask, what about the first and second cranial nerves? From where do they come from? They come from the forebrain. Okay, basically not from the brainstem. Alright, with that, let's go and take a look at the dorsal aspect. Now, when you take a look at the midbrain dorsally, it's very simple. You will see an area called the corpora quadrigemina, in which it is composed of 2 superior colliculi and 2 inferior colliculi. And in between them, from the superior part, you will see the pineal gland. As simple as that. Now, I told you about the trochlear nerve, right? See how it arises from the dorsal aspect? It arises from the dorsal aspect and it circles around and it reaches to the ventral aspect. That's simply it when you want to detect anything here. Now, what's the point of those superior colliculi, inferior colliculi? Let's take a look. Now we'll dig deep into these. Here's the pineal gland, to the 2 superior, the 2 inferior. Here, what you will see, let's go through the slide. The superior colliculi, it will project to the lateral geniculate body of thalamus via the superior brachium. So, you got your superior colliculi, you got fibers, structures passing through the superior brachium until it reaches to this part, which is the lateral geniculate body. And the opposite for the inferior colliculi, you got the inferior colliculi going through the inferior brachium until it reaches to the closest part, which is the medial geniculate body. Now, the way I remember this, superior, in my mind, I remember sight. Superior, sight, both start with an S, so it's related to the function of visual. So visual spinal reflex. Inferior, I always remember one word, actually 2. It's incoming sound. Incoming sound. Here, I wrote these here. Inferior, incoming sound. So I immediately remember auditory. So it's responsible for audiospinal reflex. Okay. So that's about it for the dorsal aspect. Now let's take a look. Let's take a cut section and take a look at the internal aspects. Before that, let me introduce you here. By the way, don't worry about the top part. This is an overview if you want to read the document. This is a nice overview of what you will expect, and the foramen menisci, which I'll come back to it later. Here, before I actually start with the midbrain, just take a look of how they are supposed to look like as a cut section. This is very nice. Look, you got the midbrain, the pons and the medulla. How I remember the midbrain, especially for radiology, I remember it as, I just remember panda ears, and it looks like, wait 1 second, it looks like panda ears, literally. And for the pons, I just remember a belly. It has a belly. And for the medulla, it's neither the panda ears or the belly. So what do I have left? The medulla. Of course, there is distinctive features which I'll be talking about later, but this is like your click terms. Like you click, you just remember these, khalas, you get them. Especially radiology. So let's take a look at the midbrain cut section. Okay. Here you got what nuclei you will see. It makes sense. The nuclei of cranials, you'll see the motor nucleus of oculomotor, cranial number 3, makes sense, we talked about it. Motor nucleus of trochlear nerve, makes sense, we talked about it. Here we have something additional. Mesencephalic nucleus of trigeminal nerve. Here, it has its own story. It's very simple. It's basically, you got a slide specifically for it, which talk about the trigeminal nuclei. It's divided into multiple parts. I'll be talking about it in a bit. Now that's from ناحية nuclei. You got your parasympathetic nuclei as well, which is called the Edinger-Westphal nucleus. And the extrapyramidal tracts, superior colliculi, makes sense, we talked about it. Inferior colliculi, makes sense, we talked about it. You got two additional structures, the red nucleus and the substantia nigra. And the red nucleus, which is responsible to motor related, and substantia nigra, we got that name because of the color, the melanin. Okay, the main tracts we will see: the cross-cerebri tracts, the four lemnisci, the rubrospinal and tectospinal, which makes sense from the extrapyramidal, as you have studied in the tractology lecture. And here we have the medial longitudinal fasciculus. This, I searched about it a bit. It's basically a collection of the oculomotor, trochlear, والabducent, so they're all eye related. And I wrote the function here for you to see. Now, for the four lemnisci, let's go here. For the four lemnisci, we got four. You got medial lemnisci, spinal, trigeminal, and lateral. We have studied the medial lemnisci, if you remember, from the tractology lecture, which is basically responsible for proprioception and fine touch. If you remember the dorsal aspect, which has those functions and such, we already talked about it in the tractology, so I will not dig deep into it. Here, same thing, spinothalamic tracts, if you remember them, which carry pain, temperature, pressure, all of those, same story. Here, you have the new things, trigeminal or lateral. Trigeminal lemnisci, which is basically, how I think about it is that it holds all of the sensory sensations, but in one nuclei, all of the sensory dorsal sensations, but for the face. So it is the band of fibers carrying pain, temperature, touch, proprioception. Contralaterally, so opposite side, the face and scalp, for the face and scalp. So that's basically for the trigeminal. And you got for the lateral lemnisci, and the first word the first thing that clicks is like really related to auditory, hearing. Okay, it is a band fibers carrying hearing impulses from both ears, mainly the opposite side and such. And I said it is the auditory related. Okay, back to the slide. Okay, we got a good overview of the midbrain. Let's take a look at the actual cut section. Before that, the cut section is divided into tectum, tegmentum, and the cerebellar peduncle. Tegmentum is basically what the first thing that clicks in my mind is the core structures. The core structures. So it contains the red nucleus, it will contain the lemnisci, and contain the other nucleuses here, for oculomotor and such. I'll show it to you in a second. And the tectum, the first thing that clicks is like the most sided structures. Okay, so I would see the superior colliculi and mainly the superior colliculi, also the inferior colliculi, and that's mainly it for the tectum and tegmentum. Okay, what about the cerebral peduncle? Cerebral peduncle, two parts. You remember two parts: the cross cerebri that we talked about, in addition to the substantia nigra. So this is this part. Okay. Now notice I have said that the tectum contains the superior and inferior, but in this cut section we see the superior. That's right, because the midbrain is cut into two parts. The superior colliculi part, if you go down, you will see the inferior colliculi part. Okay. Now, an advice is that it's best for you if you pause and you go through the structures alone, so that you get an idea of what I'm about to say, get an idea of all of them, so that you will be able to label. That's very important. You need to be able to label. Okay, first things first. You got a dorsal aspect here. Why? Because we see the superior colliculi. And here you got the ventral aspect. Why? And this is very distinctive, because you see a fossa. Remember the fossa that we talked about, the interpeduncular fossa. So you cut it into transverse section. You see it literally. So it's very distinctive. Alright? So we got an idea of this part, we got an idea of this part. Let's see the nuclei here. Here you will see the oculomotor nucleus. With it, you will see the oculomotor nerve, which makes sense to be existing here. And then you have beside it the Edinger-Westphal nucleus, which I believe it is parasympathetic related, that aids the oculomotor. So it makes sense it's located here as well. Then you got the four lemnisci, okay? And then you got one of the other core structures, which is the red nuclei. This is very important, red nucleus. Now if you go to the sides, you see the crus cerebri here and substantia nigra here. Within them you will see tracts. So in this case you will see corticospinal and corticobulbar tracts. Okay, all good. Here I have kept for you some for you to test yourself in the labeling. I got it from the internet, so it will help you to visualize things, but this should be your main source. Here's a question from the slides as well. Ask you a few questions. Is this ventral or dorsal? You tell me. This is ventral. Why? You see the fossa. This is dorsal. Why? Because you see the superior colliculi. Since you identified that this is the superior colliculi of the midbrain, so now you can expect what you will see in the middle, right? So you expect to see the red nuclei, even if this circle wasn't here, you just expect to see it there. And you'll see the four lemnisci. Be able to identify them. Now, when we take a look at the inferior colliculi, now خلصنا the superior colliculi, we had a cut section there. Now into the inferior colliculi. Let's go through the slide together and then we can go through the explanation. So here you will see the trochlear nerve fibers crossing the midline before leaving the brainstem. See, it crosses the midline before leaving the brainstem, and you got the substantia nigra because of melanin. It controls the muscle tone, and the cerebral peduncles containing what? That's important. Corticospinal, corticonuclear fibers here. That's the crus cerebri. Inside it, we see tracts. Okay, let's actually take a look at the cut section. It's very, very important for you able to identify each cut section and to be able to label. Here, first thing, most importantly, trochlear nerve. See how the trochlear nerve is passing, as we said. Remember when we said the trochlear nerve it arises from the dorsal aspect and winds around and goes ventrally. So you see it here. So when you see that aspect, you will know that this is the inferior colliculi along with this characteristic, the fossa. So the fossa made you understand this is the midbrain. So now you ask yourself, which part of the midbrain? Is it the superior or inferior? It's inferior. Why? Because of the nerve passing, and of course other structures, but that's one of the most important things you see. Other things you see here, of course, the lemnisci. What else? Trochlear nerve and its nuclei. And what else you'll see here? Substantia nigra, the crus cerebri. Within it, you will see what? The tracts. Okay. I believe corticospinal, as we said, and corticonuclear. Now that we have an understanding of this, and again, make sure you be able to label those. Now we can go and dig into the syndromes or the problems that we see. First things first, look at the picture. See the abnormality. Here, it's hitting your crus cerebri and extending into the oculomotor. By the way, what is this cut section? Superior colliculi, oculomotor nerve, right? Red nucleus, that's another characteristic. So it's hitting your oculomotor and the crus cerebri. So from there you can predict what are the things that you may see. So first things first, ipsilateral ophthalmoplegia. So because of damage of the oculomotor, and the crus cerebri, if it's damaged, معناتها you will have an effect on the corticospinal and corticobulbar, leading to contralateral hemiplegia. Now, very important. Very important. The cause: occlusion of the branch of the posterior cerebral artery. Make sure you link posterior cerebral artery. Where did we talk about it? Here. Remember this? So here we see how the oculomotor is getting damaged along with the surrounding structures. Now, how I like to remember it is just, I made this so that you can get yourself into the problem here, just to get you into the story of this whole thing. So when you say Weber's, I put a picture here. When you say Weber, whip, it sounds like a whip. So when you get whipped, you get whipped laterally, so it helps you visualize or imagine that this is the problem here. So you get whipped laterally, that's one, on the side as is mentioned here. And when you get whipped, you will eventually get what? Muscle weakness. You get tired from the hitting, muscle weakness and all of that. That helps you remember the corticospinal, the pain and all of those sensations. It helps you remember that. Along with this, when you're getting whipped, what do you do with your eyes? When you're just about to get whipped, you start closing your eyes and you're scared for your life. So you just remember the eye-related things: ipsilateral ophthalmoplegia. With all those characteristics, it's very important. Ipsilateral ptosis, you get dilated and fixed pupil. You need to go through this. Lateral squint and such. Loss of accommodation is also important. Alright? Here I have attached some tables. By the way, if you see these tables, yes, I have generated it from AI with our references. So I worked on these to get like a good reference for you to go through. Anyways, next is for the Bendicott syndrome. El Bendicott syndrome, look here. The lesion, it's hitting your red nucleus. And notice, not only the red nucleus is affected, the oculomotor. And not only the oculomotor, the lemnisci. Which part of the lemnisci? The medial part, right? So what are the features? Oculomotor is hit, so what happens? Ipsilateral ophthalmoplegia. Medial lemnisci. Back to tractology. What will happen here? Contralateral hemianesthesia, remember? Proprioception, vibration, and all of that. Medial lemnisci. صح? And you got a lesion in the red nucleus itself. Red nucleus, which is responsible for motor related, let's say. Think of it that way. That's how I like to think about it. So I will get involuntary movements. Voluntary movements and altered muscle tone along with ataxia. Okay? To help you remember this further, again, these are the tables. To help you remember this, for some reason, when I looked at the red nuclei and combining that with the name, Ben 10, if you watched the series when you were a kid, it immediately clicked that the watch of Ben 10 looks like a red nuclei. So it will help you get into the story of the Ben 10, right? Here I have enhanced on the story. If you really wanted to remember it based on that story, Ben 10 watch is a circular like the red nucleus, so you get involuntary movements when there's a lesion. Ben 10 now is old, so he has his sensors is ruined, contralateral hemianesthesia and such. Okay, and since he's old, he'll have bad eyes, so he will get ipsilateral ophthalmoplegia. And with that, we have finished the first cut section of the we finished the midbrain. Now we'll move forward with the Pons. Okay, now for the Pons. Back to the Pons. So we're done with the midbrain, this section. Now we'll go through the Pons. Okay, for the Pons, the first thing you will notice, at least from my side, is the groove of the Pons. There is a groove in the middle. This is important. Here you got a groove in between the Pons. It holds a very important structure, which is, try to guess, it is the basilar artery. Remember when I told you that in the contents here you have the circle of Willis, and I said that there is a basilar artery which is located in a different structure that structure is the pons. So the basilar artery located here, it will go move up and joins the circle of Phyllis in that area in the midbrain. So that's number one. When you go laterally, you will see the middle cerebellar peduncle. Tamam? That's another structure. If you go further down, you will see a sulcus. Okay, you'll see a sulcus. How is it named? You got the pons, the medulla, so it will be called pontomedullary sulcus. All right, and then this sulcus will hold multiple nerves. Now remember the rule, the 2-4-4 rule. We finished from the midbrain. Now we're into the pons. So we finished cranial nerve 3 and 4. Now next into the second section, which is 4 cranial nerves, which is cranial number 5, 6, 7, and 8. Okay. We will go through it in order. We have cranial nerve number 5, which is called the trigeminal nerve. This, I like to call it the lonely nerve. Whatever you like to think of it, just remember it's not within the sulcus, okay? It's here outside. So this is the trigeminal nerve, cranial nerve number 5. طيب. And now back to the sulcus. Here you will see the rest of the cranial nerves. So you'll see cranial nerve 6, 7, and 8 from most medial to most lateral. So here the most medial, so trigeminal, this is the trigeminal. So here you got cranial nerve number 6, so this is your abducent. Cranial nerve number 7, this is your facial. And then cranial nerve number 8, which is vestibulocochlear nerve. Okay. And alright, that's about it. Now, since we have the basilar artery, let's say you got an aneurysm. So obviously there will be some abnormalities here. I wrote it for you. It will affect the corticospinal. If one-sided, it will cause hemiplegia. If two-sided, it will cause quadriplegia. I'll explain it for you in a second. In the internal features, there's a whole syndrome for it. Now, من ناحية الtrigeminal nerve, if you have a pontine lesion, pons lesion, so what will be affected? Just take a guess. It is the trigeminal nerve, right? And let's go down. Yeah, here, these are the nerves. This is the slide for it. Here's your cranial nerve number 6, number 7, and number 8. Okay, pontomedullary sulcus. This is your trigeminal nerve, and here you have 2 roots, motor and sensory. I'll show it to you also in the internal features in a second. Here's an external picture for you to see the features, and this is the notes for you as well. What else? Just for you to enhance your understanding in these 2. Alright, now we are done with the ventral. Let's go dorsally. Alright, so dorsally, you don't expect to see a belly, right? So you're flipping it, you're seeing, let's say it's back spine or whatever you'd like to think of it. So the first thing I'd notice again is a groove again, right? But here it's actually not a groove, but rather a sulcus. Here you see the median sulcus in the middle. You go to the sides, you will see the medial eminence, which holds a nerve, right? It's called the abducent nerve, which is cranial nerve again 6. Go through it by order. Cranial nerve 5, you don't see it here, but you would see cranial nerve 6. And now if you go further down, you'll see a facial colliculus. This area, you'll see it facial colliculus, and it holds cranial nerve by order. Cranial nerve 7, facial nerve. And then if you go laterally, you will see a vestibular area. Okay, and this will hold your cranial nerve 8. Alright, here you see down, this is medullary stria, which are transverse bands. as it literally looks like transverse bands that separate the pontine from the medullary part. Yeah, exactly. And yeah, I have wrote the notes for you here. And then you would see the fourth ventricle very simply. The fourth ventricle, you'd see it in that area. If you look at it from the side, just imagine that you're sliding your back as the pons, your back, so you're sliding here, your back is the pons and the open medulla. And by the way, when you take a look at the medulla, when we are going to explain it further, the medulla is made up of two parts, the open and the closed. So the first part is open, so you'll see the pons, your back to the pons, and then the open medulla. And when you look up, so that's your eyes, you're looking up, you'll see what? Sorry, Bella. That's it. You'll see some extra terms or such in the slides. It's basically diamond shaped and such. It all holds the same idea. Okay. Yeah, so this is the medulla. As I told you, the open medulla and the closed. Alright. Now, into the internal features of the pons. Okay, so let's go through the slide together just to take a quick look at it. You have general features. It is part between the medulla and the midbrain. True, it is the relay station between the cerebrum and the spinal cord. Yeah, it contains regulation of center for breathing. Alright, so the main nuclei that we see, nuclei of cranial nerves. Alright, so you see motor nuclei of trigeminal nerve, cranial nerve number 5, and the main sensory nuclei of trigeminal cranial nerve number 5. This is important, remember. Here, remember when we said we have roots, I think it's mentioned, yeah. The two roots, the motor and sensory, that's important, yeah? So here it's mentioned here again. And you got motor of abducent, yeah, we talked about it, makes sense for it to be in this cut section. You have the facial, also makes sense. Here you have something new, you got solitary nucleus, we'll talk about it in a second. You got vestibular and cochlear nuclei, yep. Then parasympathetic, these are new, like crematory nucleus and superior salivary nucleus, and we'll talk about that soon. And you have the extrapyramidal nuclei, the pontine nuclei. Okay, back to the trigeminal nerve. Okay, remember when I told you I'll come back to it later? In the midbrain section, I told you I got the trigeminal nerve. So here, I made a nice table for you, an organized table. So you got the trigeminal nerve got multiple roots. So the first one is the first nuclei we see is the mesencephalic nuclei, which is located in the midbrain. And that's what I told you that in the beginning, which is a proprioception from jaw. And you can take a look at this. Next, you have the main sensory and then the motor, which is this one. Okay, and it's mentioned here as well. So the main sensory, from its name, main sensory, it's located first in the pons and it is in the mid level, yeah. And it's responsible for fine touch, pressure for the face. And then you got the motor nuclei, also located in the pons, and it is the motor muscle to mastication. And a spinal trigeminal nuclei, which is the last one, which is located in the medulla. I believe you will see it, and it is responsible for pain and temperature from the face. The most important take is the locations of the trigeminal nuclei and the functions. So I have been reading through this, it's written here. Those are the main things you need to remember from each part. So the mesencephalic is responsible for proprioception, the main sensory touch and pressure, and the spinal pain and temperature. Main sensory, yeah, spinal, and yeah, exactly, that's all. Perfect. Let's actually go through now the actual cut sections. When you take a look at the cut sections, it would make sense for you. So here, this is the cut section. Let me show you. This picture is better. This cut section is the mid level. So this is the trigeminal nuclei. We'll see the trigeminal nuclei here. divided into two first, tegmentum or basilar part. So remember, tegmentum, you see core structures. So you'll see all of those nuclei, where is it? You will see the motor nucleus of trigeminal here. You will see the main sensory of trigeminal nerve here, right? So you'll see the core structures. If you go down, it's called basilar part, which makes sense because remember the pons, which has a groove, yeah, which has a groove for the basilar artery. So in the cut section they called it the basilar part. Now if you go and take a look here, you see fibers running. Those are called the transverse pontine fibers. So it's transverse from its fiber direction, and pontine because it's in the pons. And then you see a surrounding here. This is the pontine nuclei. Within you will see bundles of corticospinal and corticonuclear, right? And that's the main take you need from here. And I encourage that you go and solve those. Try to label. It's very important to label, to be able to label. Okay. Next is another cut section, but this time instead of cutting in the midpoints to look at the trigeminal, we're cutting at the caudal end, which is at the level of the facial colliculus. All right. So here in this cut section, you will see the important structures such as here. The first one, facial colliculus, so you see the motor nucleus of facial nerve. There you go. Along with here if you track it, you'll see the facial nerve. And then you got another nuclei, which is for the nucleus of the abducent. If you track it again, you'll see the nerve for it, which is the abducent nerve. And here you see the additional structures, the middle cerebellar peduncle seen, and you have the spinal tract and the nucleus of trigeminal nerve seen in this area. Okay. And in both cut sections, notice the fourth ventricle seen, which makes sense at that level, right? Again, I encourage you to start labeling and test yourself. Now, let's go through the syndromes. Okay, look at this picture. See that it is hitting multiple structures here. Let's go through the slide. It says it is a stroke syndrome involving the inferior medial area, true, of the pons. Inferior medial area, that's true. And the basilar artery that is causing it, so the paramedian branch of the basilar artery, which is expected. If you remember that the basilar artery, as we said here, where is it here? Now I'm talking about this part. Let's go down. So the things that are affected here, so you got your corticospinal tract causing what? If this is affected, it causes the contralateral hemiplegia. The facial nerve affected, causing ipsilateral facial paralysis. The medial lemnisci is affected, along with the abducent and pontine, all causing clinical signs. Now, the doctor mentioned that there's a lot of things here, right? So the doctor mentioned that there's few things, at least that's your priority to remember. So it's a triad, and the way I remember it is by using the Foveli. By the way, Foveli is another name. So medial pontine syndrome, also known as Foveli's syndrome. So I just used the word Foveli. You take the F, which stands for facial nerve, and you got your first nerve that is affected, and you correlate that with the presenting case. And then you have LF, we're done, you don't need the O. And then you got VI, which is 6, cranial nerve number 6. Who is your cranial nerve number 6? Your abducent. So your abducent nerve is affected, right? And then finally, since it hits the tracts, and that's, you need to remember it as extra, since it hits the tracts, it will cause you contralateral hemiplegia. Alright, so we're done with the first syndrome. Second syndrome is called the locked-in syndrome. Here it's affecting this area. So, what is this area, as you know? This is the basal area, the basilar part. And it causes damage to the tracts within the nucleus and the tracts within. So it damages the corticospinal and the corticobulbar. You go down, you will see what will the patient present with. He will present with quadriplegia, no facial expression, and no speech. The eyes are the only ones that are working. And why is that? Simply because this section is spared, the tegmentum is spared, the basilar is affected. Okay, the explanation behind those presenting symptoms is basically here the tracts, the corticobulbar is affected, right? Corticobulbar and corticospinal. The corticobulbar, if you recall, it is responsible for many cranial nerves. Since it's responsible for many cranial nerves, there are fibers that will be affected going to the facial nuclei and all of those nuclei, causing those symptoms. Okay, and by the way, it's bilateral, this side and this side. That's why you have quadriplegia. And if you look here, it's one-sided. That's why you have hemiplegia. Okay, how I remember it through this picture, locked-in syndrome is a term many people use when you're trying to focus. So you're trying to lock in. So you just when you're looking in, your eyes are wide open, and that's the only thing you're using along with your brain. So that's the only thing that will be working in this syndrome. That's about it for the Pons. Okay, now into the final part of the brainstem, which is the medulla oblongata. So far we finished the midbrain, the Pons, now into the medulla. And the first thing I noticed from the features is that we have a fissure here called the anterior median fissure. So that's my starting point. That's my anterior median fissure. If I go laterally, I see this structure, and this structure is called the pyramid. And if I go laterally further, I see literally an olive-like structure called olive from its shape. And if you go laterally further, I see the inferior cerebellar peduncle. The inferior cerebellar peduncle. Now, if I go from the midline upwards, I see the same sulcus, the postomedullary sulcus. We finished the story, we don't need it. It's not related here, it's just that when you go upward, you will see it. If you go downward, you will see the pyramidal motor decussation. Pyramidal motor decussation makes sense. This is the pyramid, which has the pyramidal tract, which is a motor. So you will see pyramidal motor decussation. And for the olive, it contains an olivary nucleus, which is responsible for extra pyramidal tract, and it has its own story, which will come in a second. Now, nerves. When we talk about the nerves, it's divided into two. We have, and it's based on the fissures. Let me introduce you to them. You have first the anterior median fissure, as we know. Between those two, the pyramid and the olive, we have a fissure here called the anterior lateral fissure. And then if you go further in between the inferior cerebellar peduncle and the olive, you will have the posterior lateral fissure. Let me show it to you here. The anterior lateral fissure and posterior lateral fissure. Okay, when it comes to the nerves, remember that rule, the 2-4-4 rule. We finished from the 2, we finished from the 4, Pons, the midbrain, then the Pons, now into the medulla oblongata, the last 4. So the last 4 is 9, 10, 11, and 12 cranial nerves. Let's go into an order, like always. Let's go and see the 9th cranial nerve. The 9th cranial nerve, we will see it in the posterior lateral fissure. So we'll see it here. These. So the first 3 of the last 4 cranial nerves, we see them in the posterior lateral fissure, which is cranial nerve 9, 10, and 11. And then in the last cranial nerve, the lonely nerve, we'll see it in the anterolateral fissure as seen here. The anterolateral fissure. So this is the hypoglossus nerve, the cranial nerve number 12. These are 9, 10, and 11 cranial nerves. Okay, that's it from identifying them. Here I included some enhancement for you. That's it for the ventral aspect. Now let's go to the dorsal aspect. For the dorsal aspect, as I told you already, we have the open medulla and closed medulla. So the open medulla, which is related to the ventricle above, and the closed medulla, which is continuous with the central canal, all right, of the spinal cord. It's continuous with the spinal cord. If we go further into the dorsal aspect, so we flip it and we see a trigon, we see triangle, flipped one, we see 3 trigons, starting with the first one here, which is the hypoglossal trigon, this part. When you go downwards, which is the intermediate trigon here, you see the vagal trigon, and the most lateral trigon, which is the vestibular trigon. You can remember it by this area. Remember, this area was what? The vestibular area. So this is the vestibular trigon seen. Now, outside of this area, we have, by the way, this is the open medulla. Those exist in the open medulla. So when we leave it, we go into the closed medulla. We see the structures of gracile and kinete. Gracile tubercle, kinete tubercle. Right, and this is the information here written. Okay, now if you take cut sections of them, and let's go through the cut sections. Actually, let me go through the nuclei we see in the medulla oblongata and make sense of this slide. First, we will learn about the solitary nucleus, the nucleus ambiguous. I'll talk about them in a second. You got the parasympathetic nuclei, the inferior salivary with dorsal vagal. Dorsal vagal is important for you to remember, which is basically parasympathetic related actions. And then you got extrapyramidal nuclei and other nuclei, gracile, kinete, located in the closed medulla, which makes sense. And you can link this idea with tractology, the dorsal aspect, the sensory one. Then you got the main fibers, gracile and kinete makes sense. You got internal arcuate fibers, yeah, medial, trigeminal, spinal, medial, vaginal, and list goes on. Now, let's talk about the nucleus ambiguous. I hope I'm pronouncing it right. So you got the nucleus ambiguous, and when I take a look at it, when I see the word ambiguous, I remember ambiguous as in a person who's saying not really clear words. So I would remember that it is related to things that come out from your throat. So I remember the structures: the pharynx, the larynx, the soft palate, and I'd also remember when you're not saying clear words and such, for some reason I remember the hoarseness, I remember vagus nerve, and then I can link it as a continuous way. Vagus nerve is 10, so I just need to continue it. 9 behind it and 11 in front of it. Okay? Now, all of these, they are shared motor nucleus. They are shared ones. And with that, we go to the second solitary nucleus, which is tractus solitaris. It is also a shared nucleus and is divided into two: cranial part and caudal part. When I say cranial, I always link it to candy. Why? Because it is responsible to taste. Cranial, candy, see. So it's related to taste. Who are the ones to remember in terms of cranial nerves? I remember it like this. I take this picture and I go in order. So cranial nerve 7 in front of the anterior aspect of the tongue, then 9 at the posterior aspect, and 10 which is related to epiglottis. Okay. Right, that's taste sensation. Lateral. Now, caudal part, when I say caudal, I remember. Control, also CNC, but caudal control. Control of what? Visceral related, control of blood pressure, viscera, respiratory, peristalsis, and all of that. So when you get a lesion in this caudal part, you expect to see problems in blood pressure, problems in the respiration, all of those aspects. Okay. And the similar idea to the cranial. So you'll have, you will not be able to taste if you got a lesion here. So that's basically the idea here. When we go to the inferior olivarian nuclei, which is part of the extrapyramidal, it is the largest nucleus. Now, the way I remember this is basically literally an olive. When an olive, what I remember an olive, when it falls in an open area. So I remember that it is located at the level of the open medulla. When it falls in an open area. And when it falls, it bounces around. So I remember the effect of the lesion. Loss of coordinated movement and ataxia, and loss of balance and dose. And from there, I remember the function. So I know the abnormal. So I'll remember the normal functions, which are the coordination of muscular movement, maintenance of equilibrium, and all of that. It all makes sense. Now, into the levels of the medulla oblongata. As I said, there's two parts, which is the upper and lower. The upper open medulla and the lower closed medulla. Now, the upper, as we know, it's the normal thing, upper open medulla. But when you go into the lower closed is subdivided into two, upper closed and lower closed. Alright, let's take a look first at the upper open medulla. First, I'll just pinpoint the structures we see, and from there, we'll move forward. So, first, notice what do we see? We see the hypoglossal nucleus, we see the dorsal vagal nuclei, and the solitary nucleus, followed by downward. You'll see the nucleus ambiguous. Just pinpointing صراحة. And then, when you go further to the middle, you'll see the medial lemnisci, and you go further down, you will see a pyramid which has a distinctive shape. I'll talk about it in a second. Finally, you'll see the hypoglossal nerve passing. Now, these are the pinpointing structures I told you about for the open medulla. For the functions, we talked about the nucleus ambiguous done. All of those are done. What's left is the hypoglossal nucleus, which is motor for tongue, that's done, and the dorsal vagal nucleus, which is very important. It is parasympathetic related. Okay, so a clinical lesion will cause autonomic imbalances. Now, I want to bring your attention to something. There are certain features to differentiate between upper medulla and lower medulla, and more features to distinguish between the lower medulla, between the two parts of the lower medulla, the lower closed. So first off, for the open medulla, what you need to notice is that, notice we don't have a central canal. خلاص, so على طول we know now that this is not a closed medulla. That's one feature. Second feature is that, notice, remember when I told you the panda ears for the midbrain? So it's not that. And for the bones, a belly shape, we don't have that here. So what's left is the medulla. So خلاص, we got the medulla here. No central canal, that's open medulla. And the pyramids is not clearly identified type of pyramid, and this is more important in a second in the closed medulla. I'll talk about it in a second. That's about it for here. Now, when we go through the lower half, which is the closed medulla, again, it's divided into two: upper closed with lower closed. Very, very important to remember that the upper closed is sensory, while the lower closed is motor. Very important. Memorize it like your name. Now, when you go into the actual structures, notice you will see gracile tract, gracile nucleus, kinnate tract with its nucleus. Makes sense. Why? Because it is upper closed. It's sensory, so you'll see sensory related things. and those structures, sensory structures, will cross decussate. So you'll see decussation of medial menisci, which makes sense, right? Finally, you see the hypoglossal nerve, just to identify. And notice one more thing: central canal is there. Your central canal is seen, meaning it is a closed medulla. Now you may ask yourself, how do I differentiate between a upper closed and a lower closed? Well, there is an important identification. Notice the pyramid is very defined, while the closed, the lower closed is not defined. See, is not defined, or not clearly defined as it is in here and in here. See, clearly defined. Okay, with that we have covered the structures and how to identify each one. This is again for you to look at. This is pyramids that are clearly identified. That's done. And now let's go to the lower part. And in the lower, notice we have decussations, but the decussations here are motor. And one more thing to notice again: the pyramid is not clearly identified, meaning this makes it the lower closed. And since it is the lower closed, it means it's related to motor. If you see decussations, that's motor decussations. Notice you still, the nuclei of the sensor is there, so we don't see the crossing of them. Okay, here it just basically shows you the pyramids are not clearly identified. Okay, finally, and that's the final part of this video, you have the syndromes, which is called the lateral medullary syndrome, also known as Wallenberg syndrome. See the lesion? Pay attention to it. How I remember everything about it: I just used this mnemonic I found from last year notes, and I enhanced on it. So it says don't pick on a horse. So don't pick a horse that can't eat and can't sleep. And basically don't bully a horse. So the story is about a horse. This is the horse Miskin, and don't pick on him, basically. So let's go through each one. Don't pick is the artery, which is posterior inferior cerebellar artery. So this is the cause here. Horse, I remember two things: the picture, the main character, and hoarseness. That's a characteristic sign of a patient. And the horse that can't eat. So when I say I can't eat, so I remember something related to dysphagia. I connected to dysphagia, and I remember I connected also to loss of gag reflex. So in that category. And then you can't sleep. I remember Horner syndrome. How? Basically, you see a character of a Horner syndrome, basically a drooped eyelid, so they look like they didn't sleep. So I just link it to Horner syndrome. Ipsilateral, that's important. Okay, now further to continue the story, the horse was suffering from the sun until he can't feel the suffering anymore. So the horse lost pain sensation, lost temperature sensations because of the sun. So contralateral loss of pain and temperature. Now the heat from the sun caused the horse to feel nausea, dizzy, vertigo, and loss of balance. And on one side, that's important, ataxia on one side. Okay, so it's one-sided ataxia and one-sided contralateral loss of pain. Okay, finally, I just tell myself, hope he feels well soon and bring the cruel human to justice. From this, I just tell myself, I hope he feels well and bring the person to justice. Basically, Wallen and bring Berg. So I remember the syndrome itself, Wallenberg syndrome. or lateral medullary syndrome. Just an additional way to remember it's lateral and not medial. It's basically the horse probably got beaten from that cruel guy and he got whipped laterally. So lateral medullary syndrome. And finally, it's just medial medullary syndrome. Basically, here is the mnemonic I found from last year as well. Ants love M&M, M and M, and another M. It each stands for motor weakness, medial meniscus loss, motor tongue, and that ants, which reminds me of anterior spinal artery, which is the main cause. This is the characteristic of a patient. Okay, and that's about it. I hope this video was useful for you, and to conclude, please make sure that you go through the self-assessment, and I included the answer keys of each. Best wallah. Assalamu alaikum.